Hi everyone. I would like to talk to you about cardiovascular changes in pregnancy. So, what's the difference between a pregnant mom and a non pregnant woman? So, it's the corpus luteum and the placenta. It's actually the hormones. So, the corpus luteum and the placenta would secrete many different hormones. Among them is progesterone and estrogen. So, progesterone and estrogen would both increase your plasma volume. How? Because it makes the woman retain water. So, but let's zoom in to progesterone. So, progesterone does many different things, but mainly I'm going to talk about two things that it does that leads to cardiovascular changes. So one is decrease in SVR. How does this happen? It decreases your SVR because of it relaxes your vasculature. So when your vasculature is relaxed, there's less resistance. And because of less resistance, you get increase in cardiac output. Another thing that causes increase in cardiac output is by 40% actually in total. Another thing that causes increase in cardiac output would be an increase in O2 consumption, which is 20% increase in O2 consumption for a pregnant woman. So all these things would make the pregnant woman increase in cardiac output by 40%. But take note that this is just while they're like the baseline of pregnancy. However, when they go into labor and delivery, when they're about to give birth, on the first stage of labor, their cardiac output increases by additional 20%. Second stage of labor, it's an additional 50, and on the third stage of labor, it's a additional 80%. So imagine this stresses the heart. If your patient have a pre-existing cardiovascular disease, then you have to be extra vigilant because they may go into cardiogenic shock. Another thing that you will see that is a pregnancy change in cardiovascular system is that it would also see a change in your blood pressure. So the blood pressure on the first and second trimester would be low. Why is that? So MAP is the same. Systolic blood pressure is the same, but the diastolic blood pressure would be lower by 20% pre-pregnancy, and that is because of the decrease in SVR. And another thing that it does is that it masks the pre-existing undiagnosed hypertension. So during the first 2 trimesters, you don't see that undiagnosed hypertension. And another thing is that on the third trimester, now the pregnant woman goes back to its pre-pregnancy blood pressure. And now you will see the undiagnosed pre-existing hypertension. You will now see pregnancy-induced hypertension, or you will see already diagnosed hypertension. So as a provider, we need to decipher which one is which. And it can be hard, but it's doable with some testing. Another thing is that I want to talk about is their echo. So with their echo, um, you will see on the echo that they have left ventricular hypertrophy, and it's mainly because of, so first, the mineralocorticoids are increased, aldosterone is increased, so RAS is activated, and with RAS you have increase in sodium and water retention. So the increase in cardiac output 40%, and the increase in plasma volume from the water and salt retention, and this is also 40% increase. So because of these, you get left ventricular hypertrophy on your echo, and with that you will see your mitral valve regurgitation, your tricuspid valve regurgitation, and your pulmonic valve regurgitation, and that's all an expected change in pregnancy. It should be mild to moderate, not severe. And then what is pathologic is increase in pulmonary artery wedge pressure. It should be still normal, because even though we have these increases in plasma volume and cardiac output, you still have this decrease in SVR. So that's why this should be normal. PAWP should be normal, but if it's increased, then this is pathologic. Another thing that you will see is that because of all these changes, your hemoglobin level would be decreased to 11 to 12 grams per deciliter. And you know, the normal hemoglobin is 12 to 16. And if a pregnant mom presents to you with a normal non-pregnant hemoglobin, you should be thinking, oh, my patient is dry, because then it means that they're not increasing their plasma volume as they should. And so you have to be careful, and you have to hydrate them, or you have to be watching out for signs and symptoms of lower blood pressure upon induction. Another thing is that their RBC volume also increases by 20%. So this is called, these things, because of the increase in plasma volume, this is called dilutional anemia, which is a normal expected change in pregnancy. Another thing that is important with CV changes in pregnancy is something called aortocaval compression. So how does this happen? So because of the big gravid uterus that is pressing on the descending aorta, so now the descending aorta is getting pressed with so much pressure by this gravid uterus. So now you have less blood going to your placenta. So decreased blood going to the placenta. And then you also have, you will also see some changes in the fetus, which is the fetal heart rate would have late decelerations, and that is a sign of fetal distress, and that is an emergency, and we need to do something really fast, really quickly, to make sure that the baby is getting the oxygen, the nutrients that it needs in order for him or her to live. Otherwise, the baby can die. So the management for aortocaval compression is, of course, to relieve the pressure by something called left uterine displacement, and that's pushing the gravid uterus to the left to free the the aorta of this compression. Aorta cable compression, there's also a sequela or comorbidity that it goes with it, which is called supine hypotensive syndrome. And supine hypotensive syndrome is what happens is that the gravidatorus also presses on the IVC. And because it's pressing on the IVC, then now there's less venous return. And with a decrease in venous return to the heart, so the mom have lower blood pressure. And with lower blood pressure, lower cardiac output, lower stroke volume, lower placental perfusion. So you can imagine that this is even more expounded, and this is, the baby is gonna get even more worse. So again, treatment is left uterine displacement. So that's about it for no, I want to take note before I close that another thing that changes in the pregnant woman is this is very important, so I don't want to end this without telling you this about the clotting factors. So with the clotting factors, the factors 1, 7, 8, 9, 10, and 12, they are all decreased. No, they are all increased. And then factors 2 and 5, no change. And then factors 11 and 13 decrease, along with PTT is decreased. Protein S also decrease. In some sources, even protein C is decreased, but in other sources, protein C is not decreased, but there's no change in protein C. However, there is a protein C insensitivity or resistance. In other sources, there's also increase in fibrinogen. So what is that? What does these tell you? So it means that the pregnant woman is in a state of hypercoagulability. And so they're making more blood clots faster. So they're increased risk for DVTs by 6%. Another thing is that not only are they in a hypercoagulable state, you see they also have increased fibrin breakdown. So with the increase in fibrin breakdown, you will see that they are also breaking down fast clots. So imagine you are increasing your coagulability, so you make clots fast, hypercoagulable, and then break down clots fast, hyperfibrinolysis or hyperfibrinolysis. So you are prone, or the pregnant mom is prone to consumptive coagulopathy. So that is another thing that we need to be watchful for. So that's about it for right now. I hope you learned a lot from this short video. Go out there and take care of them pregnant moms. Have a wonderful day. Bye.